Perfect. We're live. Hi, everyone. My name is Thiv Parmasodhi. I am the founder and CEO of Hera Fertility. Today this is our third webinar / class for the series that we're doing during National Infertility Awareness Week. And I'm excited about this one because Dr. Maajid Bhat has been with us for since pretty much inception, I would say. And is our go-to guide for anything semen analysis, sperm health related. And so you guys have the honor of being able to ask questions with him. We've already gotten a bunch through emails and all that, and have cleaned it up, and we'll be posting that, and he'll be asking those. A little bit about Hera before we get started. Hera is focused on the male side of things. It's a AI-powered sperm health platform. It's focused on helping men improve their sperm health. And how we do this is help you get connected to an andrology lab that's high quality, and then be able to get that the testing that you need, and then from there give you a clear explanation of what your results mean and how you can improve it. And so that's a little bit about us and what we're going to do for this session. But Maajid, do you want to share a little bit about yourself? You have a really great background.
Yeah, Maajid Bhat. I have been in the reproductive sciences for about a decade now. In the male side of things, have held some positions at the level of director, operating labs for semen analysis in a couple of countries now. Have been doing this for a while, so have picked up a thing or two. So hopefully I'm able to answer some of your questions that you have for me today.
Perfect. I know people are going to start trickling in, and we're showing this on LinkedIn, YouTube, and Instagram. And so, excuse me, in the chat section, I'll be monitoring that. So if you have any questions that you want to ask, feel free to put them in there. We'll try to get through all of them that we have. But we wanted to make sure that we cover some of the questions that we've been seeing a lot often nowadays. And just fundamentally, what is some of these key questions that we've been hearing about semen analysis. And so I have my first question here that I would love to throw out. All right. So there we go. So the first question, just to get right into it, is around morphology. So this is one question that we hear from a lot of patients that get a testing done. How should we treat morphology? How does it impact natural conception versus IVF?
So, as per the World Health Organization, anything that's above 4% normal is considered to be a normal morphology sample. And if you have a good sample and it has good motility and good concentration, uh, you have a go ahead in normal natural conception, where there is natural selection. So morphology plays a part, but there's natural selection, and the one sperm that gets through uh, most likely will be the one that's normal and reaches the egg. While as for assisted reproduction, we tend to use high magnification microscopes to at least look at the morphology and select the best looking sperm. So that helps in selecting the best sperm. But even in those cases, sometimes we see that the sperm that looks the best may not be the best via its DNA. Those tests cannot be done at the time of the assisted reproductive procedure, be it ICSI or IMSI. But only we can see the best looking sperm, and then that can avoid some of the failures that we see during natural conception. You're on mute, Thiv.
Always still forget. Perfect. Thank you for sharing that. The next one that we have is I think an important one because especially with semen analysis, there's a lot of data thrown at you. And so here's one about what is the difference between sperm count, motility, and morphology, and which matters the most?
It's like a trick question. They all are important. You'll give weight to each one of these. So, sperm count is the concentration of sperm in your sample. So, it's counted as the number that is representative in a mill, and then how many mills you have will be the total count. So, the initial count per mill, and then multiplied by the volume of your sample will give you the total sperm count.
Hmm.
Motility is the number of sperm that are motile in the sample. So even in that, there are at least a couple of different uh, ways to check motility, either by percentage or through grading. So mostly, what is referred to in the labs and how results are given in a motility percentage. So that is the number of sperm in per hundred that are moving. It's either progressively motile, that is, these are moving straight forward ahead, or
Hmm.
it's non-progressive. So they are wagging their tails, but they're not moving progressively ahead. So progressive motility is the ones that are moving ahead and forward, and the total motility is the total of progressive plus non-progressive. Morphology is how it looks. So if it has a normal head, normal midpiece, and a normal tail, it's counted as morphologically normal.
Hmm.
And if there's a defect in any of these head, midpiece, or tail, it's counted as abnormal.
Hmm.
So we count at least 3 to 400 from a sample to then define the percent that is normal or abnormal. Mind you, it's only 4% that's normal. The sample is considered to be normal.
Gotcha. Okay, perfect. And that segues into the next question. Um, my doctor said my results are normal. Does that actually mean I'm fine? What should I do?
Uh, Continue doing what you're doing if your results are normal. Whatever is healthy for your normal lifestyle is healthy for your sperm. So hydrate regularly. I mean, hydrate yourself, exercise regularly, avoid things like smoking, alcohol, drugs, uh, de-stress, get your sleep.
Hmm.
So whatever you do to live a healthy lifestyle, you do the same. Uh, if your sample is normal, continue living a good lifestyle. Your sample will be normal. So don't do anything that you would not do normally to live a good lifestyle.
Perfect. The next one is what is agglutination? I cannot pronounce that right. Yeah, because I think this shows up on some of the lab reports.
Yeah, so agglutination is one of the criterias of semen analysis. This
Hmm.
means when the semen gets liquefied, each spermatozoa is moving alone, and sometimes what happens is that they get tangled with each other. Either it's a head to head tangling, or head to tail, or tail to tail. So
Hmm.
they form clumps. These clumps get stuck in one place, so they don't move forward. And this is what is mentioned on the report sometimes. When there is a high agglutination, we tend to wash those samples to take some of that agglutination so that we get progressively motile sperm.
Perfect. Um, I just see a great question here that I want to bring up, and it's in relation to IVF. What options are available for addressing azoospermia? Medication, lifestyle, diet, and supplements.
I think the first thing that could be done is to isolate the reason for azoospermia. If there is a block that can be removed surgically, then it's fine. Or if there is any other issue like hormonal issue that can be, the best thing for azoospermia is to go connect with your urologist.
Mhm.
And then based on the reason of the azoospermia, the next steps of your treatment can be decided.
Gotcha. And just to dig deeper, is this when you're talking about that, is that like non-obstructive versus obstructive?
Yes, exactly. So
Gotcha.
if it's obstructive, there are high chances that this could be reversed. If it's non-obstructive, then we have to find out the reason why it is. It can be so many factors, but instead of going around and looking for answers and wasting time, the best course of action is to go and then go to a urologist, get a full checkup to see what's causing azoospermia.
And I think I'll chime in on that. It's like ideally a reproductive urologist would be good because they'll know and they've seen a lot of these kind of cases, and they'll be the best judge of what treatment path you should go forward with. And then lastly, just on this, even in both cases, I'm curious, what are things outside of medication and procedures that people should be doing right away if they are diagnosed with azoospermia, like lifestyle, diet, supplement wise?
like like of course, whatever helps your normal lifestyle helps sperm.
Mhm.
So yeah, once you're diagnosed and related to the diagnosis, sometimes there is a hormonal issue or just a testicular issue that you cannot nothing can be done with diet or supplements. But sometimes if it's not, it's just a block and your semen analysis is the morphology is bad, the results there's high oxidation, there's high ROS, and then you have supplements like antioxidation supplements, and then your diet, mostly Mediterranean diet, is suggested for patients. And then get your good night's sleep, de-stress. Those are some of the things you do if it's not something that is medically related.
Perfect. Thank you for that. I know those ones come up, and frankly, we've been seeing a lot of patients with azoospermia and these kind of conditions. So it's
And
important.
and the worst part is that unless you do a semen analysis, you have no idea that you're azoospermic. I've seen so many patients in for different reason and then get diagnosed by azoospermia.
Mhm.
So I would say that use Hera to get your semen analyzed before it's too late, or get your baseline done if you're trying to conceive or planning to have a baby in the future.
Gotcha. Thanks for the plug. The next question I have is a couple parts to it. But fundamentally, the person was asking about they're about to have a semen analysis next week. It sounds like they're first. So, what's kind of the most common mistakes men make that throws off their results? And then one factor around abstinence. So, does abstinence time actually matter? What's the right window before a test?
Oh, like there's a lot of questions in there.
Maybe,
But
maybe what are things they should do preparing? Like, if you were scheduling this patient in, what are the first couple things you automatically tell them?
yeah, I think some common mistakes, like most of these clinics, they schedule these patients early in the morning, and like to wake up early, people forget to get a good night's sleep. That is very important. So get a good night's sleep and keep yourself rehydrated. Drink some water because it shows in your semen analysis later.
Mm,
So I would get a good night's sleep, drink some water, and when I go to the lab, just be relaxed. You'll be given a separate room where you could produce a sample. You don't have to get nervous. I've seen that people who get nervous, most of the times, these are the guys
mm,
who make mistakes while collecting. They don't collect the entire sample, or they're not able to do it, or they're dehydrated, and then the results are way off.
mm,
And for the abstinence, it does matter. It's recommended to at least have 3 to 5 days of abstinence.
mhm.
So I would strongly recommend uh, 3 to 5 days, not less than 3 days or not more than 7 days. So the best window is recommended. Even our physicians, they recommend 3 to 5 days of abstinence.
Hmm. Gotcha. And that's great advice there. A lot of people, I've seen some who just forget about the abstinence piece, and I think there's more and more evidence showing that. All right, the next one here is around. Are there cases where the numbers look great, but there's still a problem? What gets missed? And then what are additional tests that you can do outside of the standard semen analysis?
So yes, we've seen cases where numbers look great, but they're still not able to conceive.
Hmm.
We have to think that this is only 50% of the equation. So the male side is only half of the equation. We have a female side that's 50%. It's weighed more uh, due to obvious reasons, but we do have to take that into consideration.
Hmm.
But speaking strictly about semen analysis, like there are additional tests, DNA morphology, DNA fragmentation, morphology, redox potential, sperm, mitochondrial potential tests. So uh, if you're worried about your semen results and you have good results and still are not achieving pregnancy, you should go ahead, and if you're not done morphology, you should go ahead with DNA fragmentation test or
Hmm.
even a ploidy test to see the chromosome number of your sperm. So there are some detailed tests that are mentioned after basic semen analysis that you should do.
Hmm.
And for some people who are using assisted reproductive procedures, you should also consider seeing how your sample behaves during processing. Get it washed. We use gradient to wash or Zymote device to wash. So get it done before the procedure to make sure that your sample is getting processed and you have a good yield at the end of the procedure.
Gotcha. We did have another question about that actually, about what is sperm washing?
Okay. Yeah. So after you collect semen, normally for natural conception, it's done naturally. But
Mhm.
for assisted reproductive procedures, where there are different types, we have to isolate. There's IUI, and then there's IVF, and then there's ICSI. So for all these procedures, based on the final procedure, you decide what kind of washing you want to do. So for IUI, you want to get the maximum yield of motile, progressively motile sperm. So you tend to get all the sperm that's in the sample. So
Mm.
you washing means removing the debris and non-motile sperm cells from the total sample. So you remove the debris and the cells that we do not need for fertilization. Uh, we do washing by different procedures. The basic, most common is using a gradient, which separates motile and non-motile sperm and also different fractions. This is done by using the property of weight in the gradient solutions. So the differential weight takes out the non-motile sperm and debris and just allows motile sperm to go through. And all the sperm is collected at the bottom. The supernatant is discarded, and then this pellet is resuspended in fresh media. This is ready for IUI. Or even then, you can check the numbers of your motility, and based on those numbers, it's added for IVF.
Mm.
So for ICSI and IVF, most of the times what we do is after this gradient washing is done, we allow the sperm to swim up naturally. So all the motile sperm are collected on top of the washing media
Mm.
that's put on top of the pellet. and this is the highly motile fraction of sperm. So mostly this fraction is used for IVF
Mhm.
and ICSI.
Got it. Wow. Going.
Sorry, I lost you for a second.
Oh, there we go. I was just saying I've learned so much already, but there's a few more that are coming in, so I'm gonna
Sure.
try to not overwhelm you. But this one really segues into what you were talking about immotile and progressive. So one of the questions here is, what is progressive motility, and is that the same thing as motility?
So these are two different things. Progressive motility is the motility that is the sperm moving forward from its base and making some distance. So they're
Mhm.
going forward. And motility is the total motility. In this, we capture both progressive motility and
Mhm.
non-progressive motility. So they're not the same. Motility is the total amount of progressive plus non-progressive, whereas progressive motility is just one number where the total sperm that are moving forward, that
Got
are
it.
covering distance.
Hmm. Interesting. Okay. The next one that we have is around ICSI. What is ICSI and how does it work?
So, for all the patients where male factor issue is diagnosed, and they either don't have a lot of motile sperm or a lot of sperm at all. So, in both these cases, different procedures, as I mentioned, gradient or swim up or Zymote microfluidic devices. So, they are used to get uh, as many as um, possible motile sperm as possible. If it's not a lot, even if, for example, if there is very low number of motile sperm, you spin the whole sample down, and then you get an aggregate, the total number of sperm, and then you try to get motile sperm. So when you get these motile sperm, then you create a dish where you put these motile sperm and then get these motile sperm using very tiny needles. You cut the tail, not cut the tail, you hit the tail to immobilize the sperm. So once you have immobilized the sperm, then with another needle, you hold the egg and inject this sperm into the egg directly.
Got it.
So cases where sperm is not able to reach the egg or not penetrate the zona pellucida, ICSI is the solution for those.
Wow. Perfect. Okay. Um, and then here is around retesting. So the question is, how often should you retest and when does it make sense?
Yeah, this is a great question. We have been discussing this internally as well at Hera and at other places that I've been a part of. So, sperm is not generated overnight. For a sperm cell to form from a spermatid, from a stem cell to a finally motile sperm, it takes at least 62 to 70 days.
Mhm.
So once the sperm is formed, then it moves to epididymis where it gets its motility, and then the mature sperm is formed. So it takes around 2.5 months for a cell to become a motile sperm. So anything that happens to the sperm at this point
Mhm.
can be carried forward for this whole journey of 2.5 months. So if you want to retest and make sense of retesting, or if you're incorporating health lifestyle changes, you should at least wait 2.5, I would say 3 months.
Mhm.
So 3 months is a minimum time you should wait for a new batch of sperm to be produced and then analyzed. So if you have had an injury or if you're trying to recover,
Mhm.
I would give at least 3 months. And at Hera, as we say that we should try and have separate semen analysis at least 6 months apart to give us an idea of what your semen analysis looks like.
Gotcha. And just to ask a follow up, um, is there scenarios where if you need to retest sooner than that 3 month mark?
So, of course, if for example, you've done a semen analysis a year ago or 2 years ago and it was normal, and you try a semen analysis and it's way off,
Mm-hmm.
and then you could think of hundreds of reasons, but you're not able to make sure what happened. So in that case, if you don't want to wait for 3 months, you might do it earlier to make sure to relate which one was the real semen analysis, because it uh, no sleeping or dehydrating accounts for a lot of different variables in the sample, and even some other lifestyles like putting your laptop in your lap or taking hot baths.
Mm-hmm.
So stuff like that, it gives chances of varied semen analysis results. So in those cases, you can do it sooner than 3 months. But if you want to incorporate a change and then see the result of that change, I would say you have to wait a bit, at least 3 months.
Gotcha. I know we're coming close to time, so I'm going to just pick a few more that are remaining. This one I find interesting because you, as an andrologist, embryologist, are the one who's actually doing the test a lot of times. So here's one where it's like, my fertility clinic is making me do another semen analysis after I gave them one I did elsewhere. Why?
Uh, so, yeah, this is a good question, and people have started asking this. So I think it might have something to do with your clinic's trust on an outside semen analysis. One, and second, also sometimes different clinics create different lab reports, and
Hmm.
sometimes not everyone is aware about different grading systems, different patterns, and so they want to have a universal system where they know what everything means,
Mhm.
because there's a lot of numbers in there for everyone to pick up what it actually means. They tend to send it to the clinic that they are doing this procedure in. It
Mhm.
just makes it so much easier to have this under one roof. But number one also seems to be the reason that there is not a lot of trust on newer or other clinics rather than their own.
Gotcha. Okay. And I think we want to do one question that I have that I think would be interesting because you've seen so many. So I think it would be useful to hear your take on what's the most surprising thing you've learned from reading thousands of semen analysis.
Uh, I think the one thing is that you can never guess what the results would be based off of just the sample, looking at the sample,
Mhm.
unless you take it and put it under a microscope. Like you would have samples of 3, 4, 5, 6 mil volume, but there's no sperm in there.
Mm, gotcha.
So unless you do the tests, you don't know what your results are.
Yeah, I think that's it's interesting. A lot of people who get their semen analysis done, they would say, "Well, I provided a sample, and then it looks like it was in the cup. What are you telling me? There's zero or not much." And we have to, kind of break it down for them afterwards and explain.
Yeah.
Um, all right, there's one last one that came in, and I know, Majid, you have. I want to end off by, how could people reach out to you and all that kind of stuff. But before that, I think this question is a really good one. Um, this comes from someone saying, I have a low count, about 1.2 million per milliliter, and about 5.5 to 10% motility. I have a bilateral varicocele. I've done 3 tests so far. My physician just continued to hold off and wants me to continue to take tests. What are we waiting for?
I don't know if they've gotten treated for this condition. So I think most of the times, as I said, that it takes at least 3 months for any change in the new pattern, in the new batch of semen that's produced.
Mhm.
Uh, if you're living a healthy lifestyle, there always, most of the times, there is improvement. And 1 or 2 million per mil and 5 and 10% motility, it's still low. And I think if depending on the procedure that your physician does want to uh, involve, either ICSI or IVF. At this point, I just see ICSI with the semen analysis.
Mhm.
That's the only option for now. If you have planned and if you decide to do ICSI, I think this number should hold good. You can go ahead with it,
Mhm.
unless you want to try natural and IUI or IVF. I think
Mhm.
the physician is just trying or waiting for you to get better numbers. But if there's no improvement uh, based on these numbers, you should start looking at ICSI as an option.
Gotcha. And just one follow-up on that is typically with the like this kind of condition, they would do some sort of procedure, typically there? Is that
Yeah, a
what's the
urologist would assess and see if there is something that can be done with the procedure. If not, then general improvement with medication and other stuff, supplements, might help.
Gotcha. And then from there, they would want to wait 3
Yeah,
months.
they would want to wait if it gets better after treatment.
Got it. Okay. Thank you for that question there. Awesome. We got through a lot of questions here on our end. If you guys have more, feel free to reach out at Hera. We're always happy to help there. And then, Dr. Maajid Bhat, is there any kind of parting words you want to share? And how can people also reach out to you if they have any questions or thoughts?
Uh, the only thing that I have been advocating for is for the guys to take semen analysis sooner
Mhm.
than later.
Mhm.
It doesn't take much, but it'll prevent a lot of pain and heartache in the later years of your life. So I would advise everyone who is trying to conceive or trying to have a baby in the future to have at least a baseline semen analysis done.
Perfect.
And to reach out, I am a part of Hera. You can reach out to me through Hera. I also work at Anova Fertility. You can reach out. I'm on LinkedIn. Uh, Not a lot of social handles, but I'm on LinkedIn. You can reach out there.
Cool. Well, Dr. Majibad, thank you so much for taking the time. I know you're super busy and answering all these questions, and really appreciate it because I think this is going to help a lot of people.
Of course, my pleasure.
All right. Take care, everyone. Bye.
Thanks. Bye.